So, today we'll talk about skeletal muscle relaxants. Skeletal muscle relaxants are the drugs, the name suggests that they relax the skeletal muscles without any loss of consciousness. They are specifically acting in the periphery or centrally also. There are two types of skeletal muscle relaxants. One are central muscle relaxants we call them, and another we call them neuromuscular junction blockers. They are peripheral skeletal muscle relaxants. If we see, these drugs were being used by the natives of South America in 18th, 19th century as arrow poisons. These plants like Strychnos toxifera or Condodendron tomentosum, they were extracts of these plants were being used as arrow poisons. Then Claude Bernard, Claude Bernard, he did a lot of study on these plants, and these studies are important as skeletal muscle relaxant, but they gave a lot of insight in neurohumoral transmission. First of all, he tried to give it like in the lymph sac and then block the blood supply to the muscle, gastrocnemius muscle, and then stimulated the sciatic nerve. Thereby he found out that this action of these drugs is peripheral. They are not acting on the central nervous system. Then he further studied that if it is applied directly on the muscle, there is no effect. If they are applied on the sciatic nerve, there is no effect, and that means they act on neuromuscular junction. Later on, the techniques of iontophoresis and others were developed, and this is now proved beyond doubt that they act on neuromuscular junction. Actually, they act on cholinergic receptors, that is nicotinic receptors which are present at neuromuscular junction. These nicotinic receptors are of two types. One are those which are present at muscle end plate, nerve muscle end plate, which are NM type, nicotinic muscular type, NM type, and another as nicotinic nerve type, that is NN, which are present in the ganglion. So these drugs, like the classical D-tubercularine, that will act on both, but the drugs which were developed later, they have selectivity to neuromuscular nicotinic receptors. This nicotinic receptor is a sodium channel receptor. It's basically a ligand-gated ion channel. Classical example of ligand-gated ion channel that we have talked so many times in the past, that it has pentameric structure, 2 alpha subunits, 1 beta, 1 gamma, 1 delta. These 5 subunits, they come together in a floral architecture and form this channel, form this receptor. When the acetylcholine binds to these 2 alpha subunits, then this opens and the sodium is allowed to enter in this through this channel. This sodium is positively charged, so this will enter and will depolarize the muscle fiber. This is what normally happens. What these drugs they do, they block this sodium channel, so the depolarization of muscle fiber cannot take place. One thing. We should also remember here that these nicotinic muscular receptors are also present presynaptically at the nerve terminal, and they are facilitatory in nature. Means when they are stimulated, then more acetylcholine is released in the synapse at the neuromuscular junction. So they are present postsynaptically as well as they are present presynaptically. Now, how these receptors are blocked? There are two mechanisms. One is competitive inhibition, and second is non-competitive, and accordingly we call it non-depolarizing type of block and depolarizing type of block. We'll talk about that. First of all, we'll talk about non-depolarizing block. Means competitive inhibition of nicotinic muscular receptors. How does this happen? Actually, the structure of D-tubercularine, it has two nitrogen molecules, like we had nitrogen molecule in acetylcholine that was positively charged and that had affinity for the receptor. So here also, if we see, I will just try to draw the diagram of D-tubercularine. It's not important to remember this. I just want to show you what is the quality of this D-tubercularine, that it blocks these receptors. So see, this is such a bulky compound. There are 6 of these structures, and this is positively charged, this is positively charged. Something like this. Bulky compound. That is why Bovet in 1951, he called this pachycurare. We call them curare compounds or curare blockers. So the name has come from D-tubercularine, so we call them curare compounds. So pachycurare means this is bulky, and so when suppose this part it goes and binds with the nicotinic muscular receptors binding site, then this does not allow the conformational change in that receptor to happen, and it does not open. This blocks it. Compared to this, this is curare compound, and if we compare it with the depolarizing blockers like succinylcholine, what is the difference? Decamethonium, succinylcholine, they are also muscle relaxants. They act on neuromuscular nicotinic receptors only, but they do not cause inhibition, competitive inhibition. What they do, they depolarize these receptors. We'll talk about that. So what is the difference? Decamethonium. So 10. See, this molecule is long but thin. if we compare with D-tuberculorin. Similarly, if you see succinylcholine basically is binding of two acetylcholine molecules only. What was acetylcholine? We had read in cholinergic transmission. CH2, CH2, COO, CH3, this was. So now these two molecules will combine so this also is a thin, slender but long molecule. So there is a difference between activity of succinylcholine and D-tuberculorin. What is that difference? What is that difference? D-tuberculorin like compounds, D-tuberculorin was original, and then there are so many semi-synthetic, synthetic compounds which are formed. We'll talk about them. So what do they do? So we were talking about the difference between non-depolarizing and depolarizing type of blockade. Non-depolarizing also we call it competitive. Competitive means the neuromuscular nicotinic receptors, they have been competitively blocked, and so the muscle, though the muscle is ready to be depolarized, but it cannot be depolarized because the receptor is not working, it is blocked. And another is depolarizing type of blockade. In depolarizing type of blockade, the drugs like succinylcholine, the compound like succinylcholine, it has gone and bound with this receptor, nicotinic receptor, and it has opened it. The sodium has entered. Now the problem is this succinylcholine, it cannot be metabolized by cholinesterase that is present at the neuromuscular junction. It is resistant to that. It cannot be metabolized, and this also does not detach from that receptor, and so this receptor will remain in inactive state. Remember, there are three phases of a channel: resting, active and inactive. So this will remain attached and this will go in inactive phase. What will happen gradually? The muscle action potential, we call it. Suppose this was initially -80 inside the cell. Now this will start decreasing and this becomes say -50. So the muscle is partially depolarized. The muscle is partially depolarized. Remember, in case of mammalian muscles, we have also come across this phenomena of phase 1 and phase 2 blockade with depolarizing blockade. So phase 1 is what we have talked about, that the succinylcholine is bound with the nicotinic receptors, the sodium channel had opened, and because of that, what is the characteristic of depolarizing blockade is depolarization of muscle. So when the muscle is being depolarized, remember, this is not a coordinated contraction. We have given succinylcholine from outside. This will take time in reaching at all the fibers. So what we get is fasciculations and twitching of the muscles. Fasciculations and twitching is the sign of depolarizing type of blockade. The muscle is contracting, but after some time, say after 5 minutes, this muscle will no more contract. This will go in partial depolarization, and this is known as phase 1 block. The muscle, when we see, the muscle is partially depolarized, so it cannot be stimulated further. With time, what happens? With time, we find that the muscle action potential has recovered. This has become say -80 or -90, but even now the muscle cannot be stimulated. This cannot contract. And what is the reason for that? The reason for that is that the receptor has been desensitized. The muscle is ready to contract, but the receptor has been desensitized, and so it cannot contract. So how do we differentiate between these two types of relaxation, with two types of blockade, that is non-depolarizing and depolarizing? There are various methods, but one or two characteristics we have to remember. One is known as fade phenomena. Fade phenomena, we will talk about that, is when we give repeated stimulation. When we give repeated stimulation, then the strength of contraction will gradually decrease. Remember, the anesthetists, they need to use certain protocols to find out whether the muscle has been paralyzed or not. And after the surgery, they need to know whether the muscle has recovered or not. These two things the anesthetists, they need to know. So what do? They follow a protocol. That protocol, one is known as train of 4, TOR. You will find written in the books, train of 4. So what is that? They give 4 stimulations over a period of 2 seconds. So in the ulnar nerve, the stimulation is given, and then we see the contraction of the thumb. That is abductor muscle is contracted, abductor pollicis is contracted. So what is the force with which it is contracting? It is measured. In normal muscle, in normal without any drug, what will happen? All these contractions will be of same force. But if I have given non-competitive blockade, then what will happen? Non-competitive blockade means so what is measured? The force of contraction of first and fourth. What is the ratio? This gives an idea. And why does this happen? If we have given non-competitive blockade, then why the muscle is contracting? We should remember that we have blocked the functional nicotinic receptors, but there are many receptors in the vicinity which are reserved receptors, and a lot of acetylcholine is stored in the nerve terminal. Remember, we have blocked the receptors, we have not blocked the release of acetylcholine. So when we give depolarization current, then what will happen? A lot of acetylcholine is released in the nerve cleft, neuromuscular junction. So all those reserved receptors will come into play and some contraction will take place. But when we give repeated stimuli, then those receptors are also blocked, and that is why this train of 4 is used. If you repeat the stimulation, then those receptors will also be blocked. If you compare it with depolarizing type of blockade like with succinylcholine, this fade phenomena is not seen. What happens? We do not get the full strength, lesser, but no fade phenomena. They are same, less but equal. This is because there the muscle is partially depolarized and we can stimulate it. There is no problem with the release. We are not blocking the release of acetylcholine. So this is the difference between these two. Another protocol that is followed is dual, or you give 2 stimulations, and that is 3 followed by 2. Because in this, when we give 4 stimulus, it is experienced that there is a lot of pain. You are repeatedly contracting the muscle. So what is given is 3 followed by 2. That is dual stimulation of 50 Hz, 0.2 millisecond at a gap of 750 millisecond. Same thing is observed. In these 3 also, there would be difference, and then these 2 will be very less. So what we measure is what is the difference between the first stroke and the second stroke. Again, in depolarizing type, they will remain same. There will be no difference. And when I say non-depolarizing type, remember, when I say depolarizing type, then I am talking about phase 1. In phase 1, we are able to. In phase 2, it becomes like flaccid paralysis because the receptor has been desensitized. So this is the difference. Then we were talking about titanic depolarization. Titanic depolarization is something where we give very high frequency stimulation for 5-6 seconds. 50 to 100 Hertz current is given for 5-6 seconds. So what will happen? Suppose initially I was giving like a stroke of this train of 4. So what will happen? What is fade phenomena? This initial, then this will decrease, this will decrease further, this will decrease further like this. And at this stage, suppose I give a titanic stimulation, means high frequency current for 5-6 seconds. Then what will happen? Something like this. It will not be that high, but there will be stimulation of this muscle. There will be contraction of this muscle with this titanic stimulus. Very high frequency current for 5-6 seconds. So there will be contraction of this muscle. And after this we will be, even with normal stimulation, we will be able to get like this. So this had faded to this level, but when I gave titanic stimulus, then I am again able to get some stimulus. This is known as post-titanic potentiation, because this has activated more acetylcholine has come from the proximal parts of the axon. Remember, there are certain vesicles which are present in the nerve terminal ready to be released, and there are other vesicles which are stored in the nerve body and in the axons. So all of them, they come into play. So post-titanic potentiation is observed in competitive type of blockade. Competitive means non-depolarizing type. If I give, suppose at this stage I give neostigmine. What is neostigmine? That is cholinesterase inhibitor. So what will happen? The concentration of acetylcholine will increase in the neuromuscular junction, and I will be able to contract the muscle again. Everything will reverse. That is the quality of competitive blockade. If I increase the concentration of acetylcholine in the neuromuscular junction, then I will be able to get full contraction. That is the quality. This is not seen in depolarizing type of blockade. In depolarizing type of blockade, like with succinylcholine, neither will you see this, nor there will be post-titanic potentiation, and there will not be any recovery with neostigmine. Rather, the blockade will become more with neostigmine. Why? Because already the receptor is going into desensitization, and on that we are increasing the concentration of acetylcholine. It is also observed in competitive type also. Remember, particularly with D-tuberculin like drugs, that if we give them in very high concentration, Then sometimes they also show non-competitive, and we get confused that it is behaving like depolarizing type of blockade. Why is that happening in case of drugs like D-tuberculorin? Because it is said that in very high concentration they enter in the channel and they physically block it in very high concentration that we normally do not use, but experimentally they enter in the channel and physically block it, and this blockade then will become irreversible, non-competitive. We will not be able to bring them out of that channel. So there it is not because of competitive blockade, there it is because of physical presence of the compound at the nerve terminal. So this is the difference we have to understand between non-competitive or competitive or non-depolarizing type of blockade that is seen with drugs like D-tuberculorin, and depolarizing type of blockade that is seen with drugs like succinylcholine and decamethonium. Which are the drugs available with us? D-tuberculorin, have kept it separate because the action starts within say 4 to 6 minutes, and this remains up to, I would say, 1 to 1.5 hours, 60 to 90 minutes. So this is D-tuberculorin. Actually, D-tuberculorin does not have only this effect. This also blocks ganglion. We have talked about that in the beginning. D-tuberculorin also blocks ganglionic receptors. It also causes the release of histamine. And because of this, the effects with D-tuberculorin, they become very complicated. What will happen if ganglions are blocked? Sympathetic stimulation is gone. At the same time, this is releasing a lot of histamine also. So all these effects will produce severe hypotension. Severe hypotension. And there will not be tachycardia because vagus is also gone. It is also not working. So all these effects, when they come together, they produce a very complicated picture. There can be bronchospasm also because of histamine release. So that way D-tuberculorin has all these effects also. There may not be much effects on GIT and other organs, but these two effects we have to remember. Along with effects on skeletal muscles, D-tuberculorin also has effects on CVS, vasodilatation, and remember, when the muscles are paralyzed, venous return also is decreased. So all these effects will lead to what? Hypotension, and severe hypotension, and release of histamine. This will also be a problem. So why is this happening? Because of ganglion blockade and histamine release. It has other effects also. Other drugs which are developed later on, they do not have this ganglion blocking property. But remember, the competitive type of blockers of nicotinic receptors, they are grossly of two chemical nature. One are known as aminosteroids, and others are benzyl isoquinoline. Why I am talking about them? Because these benzyl isoquinolines, they have this tendency of releasing histamine. Aminosteroids, they do not have this quality. They do not release histamine. Which are these benzyl isoquinolines? Remember, The names of these curare compounds, you will find they end with either nium or ium. See here, nium, and here it is ium, IUM. So the drugs which are ending with ium, they are benzyl isoquinolines, and those which are ending with nium, they are aminosteroids. So grossly we can classify them, we can divide them into, because that is the only quality we need to know, what is the duration of action. So we can divide them into long acting, intermediate acting and short acting. These are the long acting drugs: pancuronium, nium, pipecuronium and doxycurium. Remember, benzyl isoquinolines, there are 3-4 of them we have to remember: doxycurium, atracurium and mivacurium. Atracurium is also available in cis form, cis atracurium. So there are 3 or 4 of these benzyl isoquinolines which are used: DAM, doxycurium, atracurium, mivacurium. DAM. Doxycurium is long acting. Then which are the intermediate acting? Vecuronium, rocuronium and atracurium and cis-atracurium. This is the cis isomer of atracurium. Remember, another quality of these benzyl isoquinolines is they undergo Hofmann biotransformation. Hofmann biotransformation is when the compound automatically takes a different shape. So it gets transformed automatically in the plasma without help of any enzyme. That is known as Hofmann's biotransformation. So these benzyl isoquinolines, they undergo this Hofmann's biotransformation also. Another difference is they are metabolized by pseudocholinesterase in the plasma. On the other hand, if you see aminosteroids, they are either metabolized in liver and then they are excreted in bile, or they are unchanged excreted in the urine through kidney. That is the difference in the pharmacokinetics of these two. So vecuronium, rocuronium and atracurium. Here I was talking about this. This cis isomer of atracurium, this does not have this histamine releasing characteristic. That is why this cis isomer is used. This is an enantiomer, atracurium. It's a racemic mixture. Atracurium is a racemic mixture and cis forms is an enantiomer. So this cis atracurium does not have histamine releasing characteristic, and so this is used nowadays and not the atracurium. Then these are short acting: mivacurium, ium. So it is a benzyl isoquinoline, and another is succinylcholine. These are short acting. So when do we say they are long acting? When do we say they are intermediate short? Remember, grossly I am telling you, if the action starts within 4 to 6 minutes and suppose the effect lasts for around 1.5 hours, 90 minutes, 100 minutes, then we call them long acting. If the action starts within 2 to 4 minutes and the effect remains from half an hour to 1 hour, then we call them intermediate acting. And the short acting ones, mivacurium, it has effect for around 15 minutes, and succinylcholine, it has effect for hardly 8 to 10 minutes. So these are short acting. Succinylcholine, remember, succinylcholine is the drug of choice for smaller procedures like intubations, endoscopy, bronchoscopy, where you need a muscle relaxation for a very small time. Even though Succinylcholine, it releases histamine. This causes stimulation of ganglion. It's a depolarizing. So initially there will be stimulation of ganglion that will lead to increased sympathetic activity and tachycardia. But even then, succinylcholine is used. Why? Because the effect is very short-lived. The effect is for hardly 8 to 10 minutes. And during this period, the procedure is completed. So this is even favorite. Then second choice can be atracurium. Remember another difference why we prefer for these procedures succinylcholine. Because with succinylcholine initially, if we see the sequence of muscle relaxation, with competitive blockers, the muscle relaxation will start from smaller muscles like fingers, then it will come to fingers, eyes, then it will come to limbs, after that it will come to face, and then trunk, and ultimately diaphragm. This is the sequence that is followed. In case of depolarizing blockers, the first it starts from neck, then limbs, and then face, and then trunk, and then diaphragm. So first of all, when we give succinylcholine, our neck muscles are paralyzed. That is another reason. Compared to this, we'll suppose you are going for eye surgery, then we will prefer competitive type of blockade, because even in smaller concentration the eye muscles are paralyzed. So these are other considerations also. Then we have talked about pharmacokinetics, and normally you will find that the effects of these drugs, amino steroids, they are terminated mostly by diffusion also. Initially the muscles which are having huge blood supply, they will be paralyzed, and then from this the drug will go to other non-muscular organs and muscles will recover, and gradually these will be excreted in the urine. That is what normally happens in amino steroids. Benzyl isoquinolines are metabolized in the body and then excreted. These are the interactions of these drugs with thiopentone sodium. Remember, we do not mix them in the same syringe. They interact chemically, so we do not mix them. With general anesthetics, remember, we'll talk about that in general anesthetics. There's something known as malignant hyperthermia. If we are giving them with fluorinated anesthetics, then this malignant hyperthermia may occur in some cases where ryanodine receptors are involved. Abnormal ryanodine receptors are there. Cholinesterases we have talked about, they will reverse the effect of competitive blockers. Antibiotics, say aminoglycosides. Actually, aminoglycoside, it inhibits the release of acetylcholine. So this will potentiate the effect of these competitive blockers. That is why we need to reduce the doses of these muscle relaxants. Calcium channel blockers will have similar effect because stimulation is inhibited. Diuretics. Remember, succinylcholine. Another important side effect of succinylcholine is hyperkalemia. This pushes potassium outside the cell. Diuretics, they do what? They cause potassium problem, and so arrhythmia. The chances of arrhythmia are very high when we are using them with diuretics. This causes hypokalemia. Diazepam, it's a muscle relaxant, centrally acting muscle relaxant. Diazepam, propranolol will also have blocking property. Quinidine, remember these are antiarrhythmic drugs. Quinidine is class 1 antiarrhythmic drug. So this acts on sodium channels. It blocks them. So they will have additive effect. So these are interactions that we have to keep in mind. This is Sugammadex. I have specifically want to talk about it. This is like a chelating compound. This chelates these competitive blockers, and so what will happen, the effect will be terminated, but not because it is acting at neuromuscular junction. This is interacting with the free competitive blocker, curare blockers, and so it chelates and then it is excreted. But when it is chelated, then more of the drug which is bound will come and will become free. So gradually the drug will be shifted from the receptors and will be chelated with this drug. So this has a unique mechanism. That is why I have talked about it, Sugamadex. These are the problems with this. Respiratory paralysis has to be there. That is why actually we are giving it. So paralysis, the thing is, how much time will be taken for recovery? Remember, diaphragm we have talked about, this is paralyzed in the end, and this will recover first. This is normally happens. So respiratory paralysis is there, flushing because of release of histamine. Flushing is there, fall in BP we have talked about because of ganglion blockade or because of histamine release. Both they will have cardiac arrhythmias, again because of so many blockades. In some cases, like in acetylcholine, there will be tachycardia. With rest of them, there is bradycardia. Asthma attack, again because of histamine release. Muscle soreness, this is more common with depolarizing type of blockade like succinylcholine. The muscle after recovery, it feels sore. There is pain in the muscles because of fasciculations during the process. Malignant hyperthermia we have talked about when we give along with fluorinated general anesthetics. Then we see malignant hyperthermia, and how do we treat that? We treat that with another, we call it directly acting muscle relaxant, that is dantrolene. This is also muscle relaxant. The third type we can remember when the question comes in the exam. This is also muscle relaxant. We call it directly acting because this acts on RYR1, rhinodyne 1 receptors, which are present in the skeletal muscle. This does not block RYR2, which are present in the myocardium and in smooth muscles. So what is this RYR? This is present in the sarcoplasmic reticulum. So when we give general anesthetics fluorinated with these muscle relaxants, what happens? These, if they are abnormal in nature, then they get opened. A lot of calcium is released in the cytoplasm, and because of that there is contraction of the fibers, muscle fibers. This contraction of the muscle fiber increases the temperature. That is how our body temperature is increased, by contracting the skeletal muscles. That is one of the mechanisms. So this causes hyperthermia, and this hyperthermia is resistant to non-steroidal anti-inflammatory drugs. So what do? We have to give dantrolene, that is the drug of choice, 1 milligram per kg. And what will it do? This will block these rhinodyne receptors. So this way, this is causing muscle relaxation, but we don't use it for the indications for which we use other muscle relaxants. This is specifically used for malignant hyperthermia. And what are the uses of these muscle relaxants? One is naturally with general anesthetics we need muscle relaxation. For other procedures also, not only with general anesthetic, for intubation, in bronchoscopy, endoscopy, where we need relaxation of muscle. Assisted ventilation. When we are putting the ventilator, we need to paralyze the intercostal muscles. Otherwise, ventilator will not work. It will not be able to inflate the lungs and it will damage the thorax. Convulsions. Status epilepticus. Sometimes when nothing is working, then we have to paralyze. Otherwise, there is a lot of injury to the body. Similarly, in ECT, when we are giving stimulus to the brain from outside. This causes severe contraction of muscles and there is injury, tear to the muscles. So in these cases also, in electroconvulsotherapy, we need to first of all give muscle relaxant so that injury is not there. Tetanus also, sometimes when there is severe spasticity, we need to give muscle relaxants. Then we come to centrally acting muscle relaxants. They were acting on neuromuscular junctions. They are causing paralysis of the muscles. These centrally acting muscle relaxants, they act on polysynaptic reflexes, and that is why they affect the tone, resting tone of the muscle, but the voluntary movements are maintained. This is not the case with neuromuscular junction blockers or competitive or non-competitive muscle depolarizing blockers or non-depolarizing blockers. Here, normal activity is maintained. The tone that is maintained by polysynaptic reflexes, which are mostly going through reticular activating system, spinal and supraspinal levels. That is the place where these centrally acting muscle relaxants, they work, either spinal level or supraspinal level. I told you reticular activating system, but they usually do not affect the monosynaptic stretch reflexes. That is why normal activity is not affected, but the tone that is maintained by polysynaptic reflexes, that is relieved. They are mifenesin was the first drug that was discovered. Mifenesin, this was actually called internuncial neuron blocker. Internuncial neurons in the spinal cord is the place where mifenesin blocks. But then it was found that if we give it orally, severe gastritis, severe irritation. And if we give it IV, then what will happen? This will cause thrombophlebitis, hemolysis. At this stage, I would also talk about these competitive blockers or muscle relaxant that we have talked about, peripheral muscle relaxants. We have talked about the structure, quaternary ammonium compounds. So they are not absorbed orally. They have to be given through IV route, and their volume of distribution would be very less. They cannot easily cross plasma membranes. They cannot cross blood-brain barrier. They cannot cross placenta. So they have a very less volume of distribution. Here, centrally acting muscle relaxant, they do not have that problem. They can cross all these organs. They can cross blood-brain barrier. They can cross placental barrier also. So mifenesin, this caused severe thrombophlebitis and hemolysis. That is why it went out of favor. And these are the compounds which were developed, which are known as mifenesin derivatives, like carisoprodol, chlorzoxazone, chlormizanone, methocarbamol. These are mifenesin derivatives. Then other drugs that we have, one is benzodiazepines, diazepam. This is a muscle relaxant, centrally acting muscle relaxant, acting through GABA A receptors. We know benzodiazepines, they facilitate the GABA activity, acting on GABA A receptors. Then baclofen. Baclofen acts on GABA B receptors. Remember, GABA A receptors are ligand gated ion channels, ligand gated chloride channels. And so when we give benzodiazepines, they potentiate the effect of GABA, and chloride channels are inhibitory in nature, and that is why they are effective as muscle relaxant also. Baclofen acts on GABA B receptors. GABA B receptors are G protein coupled receptors, but their transduction mechanism involves beta gamma subunit of G protein, and this causes opening of potassium channels. So this is also inhibitory in nature. So baclofen and thiocolchicine, these two drugs, they are having almost similar function. So these drugs, particularly baclofen, is used in conditions like multiple sclerosis, amyotrophic lateral sclerosis. These are the conditions where baclofen is used. Surprisingly, it is not found to be very effective in other spastic conditions. Even in cerebral palsy, this was not found very effective. So this is used in multiple sclerosis, amyotrophic lateral sclerosis. Thiocolchicoside, I have told you it is a colchicine derivative, but this is having GABA activity also. Tizanidine, alpha 2 agonist, adrenergic, but alpha 2 agonist. Alpha 2 receptors are present presynaptically, and what do? They inhibit the release of norepinephrine. They are present in the periphery, they are present in the CNS also. So tizanidine, it inhibits the release of norepinephrine in the synaptic cleft, and because of that it decreases the sympathetic activity. That is a side effect. So when it is working in the spinal level, then it is found that it inhibits polysynaptic reflexes, and this behaves like diazepam. So these are the drugs that we have as central muscle relaxant. Where do we use them? Acute muscle spasm, say because of overstretching of muscle, because of stretching of tendon, injury, tear to muscle, tear to tendon, tear to ligaments, bursitis, tendonitis, because of rheumatic conditions also. So in all these conditions, what we can do, we can use mifenesin derivatives. Effective. Torticollis lumbago, again same. There is contraction spasticity of specific muscles, and because of that there is problem. There also the treatment is almost same, just like acute muscle spasm. These mifenesin derivatives are effective in these conditions. Anxiety. Remember, because of continuous anxiety and tension, some of the muscles, particularly of the neck, they go into spasm, and sometimes it becomes very difficult. So in those cases, drugs like diazepam, it is not only anti-anxiety, but this will also act as muscle relaxant and relax those muscles. Spastic neurological disorders, many of them, like I told you about cerebral palsy, also some spinal injury, amyotrophic lateral sclerosis, multiple sclerosis, rheumatic conditions, there are various neurological conditions. In these conditions, it is found that diazepam or tizanidine, they are found very effective, but mifenesin derivatives are not found very effective in these neurological conditions. Tetanus, again diazepam like drugs. There are other conditions also, like sometimes you have to, in orthopedic conditions, you have to reduce some fracture, or you need to do some small procedure. There also they are used. We have talked about ECT also. So in all these conditions, we are giving central relaxants, particularly drugs like diazepam. They are very effective. So this is about skeletal muscle relaxants.